Well, good morning, everyone. Welcome to the 2022 Health Michigan Healthcare Economic Forecast, sponsored by Blue Cross Blue Shield of Michigan and Priority Health. We are excited to share highlights from the 2022 health check data and hear from healthcare leaders the latest trends in health. My name is Dr. Lola Koch. I'm the acting dean of Kirchhoff College of Nursing and responsible for this health campus event. I'm working in partnership with our Seidman College of Business. So let's begin with a word of welcome from Dr. Chris Plouffe. Chris is the interim provost and executive vice president of academic affairs here at Grand Valley State University. Good morning, Chris.
Good morning, Dr. Koch. Appreciate the introduction and appreciate all of those who are joining us to review this important study that helps us in looking at the trends that will be facing us in the coming year related to the healthcare community here in West Michigan. I'm happy to be able to share with you the introduction here of the 2022 West Michigan Healthcare Economic Forecast, which is something that's brought annually to the community through partnership with our partners in West Michigan, but hosted by Grand Valley State University. In particular, I wanted to point out and thank our panelists today. We have our faculty from our economics department who are the key members of bringing together the information that will be shared here today, that will be, again, supplemented by the information from our healthcare leaders throughout our West Michigan community. Grand Valley is a leader in healthcare education, not only in West Michigan, but throughout the state and the Midwest. We offer one of the broadest portfolios of healthcare related educational programming with degrees and offerings ranging from certificates to bachelor's, master's, and doctoral degrees. This past year alone, Grand Valley graduated over 1,200 students from our healthcare related programs. And that's not even to mention all the programs that complement the healthcare industry, including in the areas of business, engineering and computing, communications, education, public administration, and our arts and sciences areas. And we truly are proud to be able to partner with our local community to bring you this year's report. So with that, I'll turn it back over to Dr. Koch and we'll get into it and hear some more about what the forecast is for this coming year.
Thank you, Dr. Plouffe. First, a few housekeeping tasks. This program is recorded and will be posted on the Health Campus Events website for all participants to refer to in the future. Also, the chat feature has been disabled as well as your cameras. And the only way that you can ask questions is through the Q&A function on the Zoom website. Dr. Simons and myself will be asking the questions during each of the discussion periods based on what we see in the Q&A. So with that, I'd like to begin the program. I'd like to introduce Dr. Jerry Simons, Professor of Economics from Seidman College of Business. He will introduce the first portion of our program. His team analyzed data from the health check that will be presented today. Dr. Simons.
Good morning. Thank you, Lola. We're happy to make this presentation today. Our health check presenters today are Drs. Daniel Montanera and Erkman Aslim. They both joined Grand Valley in 2020 as assistant professors of economics in the Seidman College of Business. Dr. Montanera earned his doctorate in economics from the University of Western Ontario in 2013. He was previously a faculty member in the Institute of Health Administration at Georgia State University, and he specializes in health economics and public economics. One of his research areas is in defensive medicine and its impacts on healthcare spending and consumer access to care. Another is on applications of auction theory in designing efficient health insurance exchange mechanisms. Dr. Montanera has published his research in the Journal of Law, Economics and Organization, Information Systems Research, and the European Journal of Health Economics and the International Journal of Health Economics and Management. In his consulting work, he has collaborated with Mathematica Policy Research in developing guidance for states regarding the best ways to incorporate competitive bidding into their procurement process in Medicaid managed care programs. Dr. Aslim earned his PhD in economics from Lehigh University in 2018. He was previously a faculty member at Minerva Schools at KGI Claremont Colleges and a postdoctoral research associate at the Private Enterprise Research Center at Texas A&M University. He specializes in health, labor, and public economics. His current research is on the impact of public health insurance on healthcare and labor market outcomes, and how social safety net programs affect criminal behavior. He is published in various journals, including Labor Economics, the Journal of Policy Analysis and Management, Economic Modeling, and the Journal of Substance Abuse Treatment. Dr. Aslam's quotes and writings have appeared in The Appeal, CGTN America, WGBU News, Michigan Radio, the Holland Sentinel, and the Center for American Progress. So as Lola indicated, our format for this panel will include a 30-minute presentation followed by a 10-minute question and answer segment. We ask the audience to use the Q&A tool at the bottom of your screen to submit your questions as we move through the presentation. You can submit your questions at any time, and they will only be visible to the panel members. So with that, I'll turn it over to Drs. Montanera and Aslam. Dan, I think you're still muted.
How about now?
Perfect.
Look at that. I was the first one to do it. Thank you very much. Thank you, Jerry. Thank you to everybody. Speaking for myself, for my GFESU colleagues, we're just so pleased to be back for the 2022 edition of Health Check. To the GVSU administration, our industry partners at Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health, and to everyone joining us today, thank you for your interest and your support. What I'd like to do, if this works, there we go. I'd like to open with a brief update on the status of some of the trends we identified last year. For the most part, we're seeing a continuation of those same trends and a little bit of stability in spending on chronic conditions, which is pretty remarkable given how different the past couple of years have been. What Dr. Aslam and I will be speaking about mostly, though, is disparities in healthcare. This was brought up at a previous Health Check meeting, and it's something we were very keen to investigate. From there, Dr. Aslam is going to take over. He's going to describe his findings as they respect to pain medication use and provision, as well as some evidence of nurse burnout and downskilling, compositional changes among nursing staff. So first to benchmarking communities. So this is where we wanted to look at some key health and spending indicators in Grand Rapids as they change over time, and then compare those changes to those in some reference communities. So you can see here, this is a bit of the story of last year's Health Check. In dark blue at the bottom is Grand Rapids. So what this is showing is hospital admissions per 1,000 population. And you can see historically, and even still today, Grand Rapids has enjoyed a bit of an advantage when it comes to measures of healthcare spending and utilization like this. But you can also see that over time, some of the benchmark communities are creeping down and approaching Grand Rapids. So you can see the US average in light blue, it's approaching Grand Rapids in terms of its hospitalization rates. Same with, well, Detroit is a kind of plateaued, while the other one is the benchmark communities. So what this is kind of a composite of cities that are comparable to Grand Rapids in terms of their industrial and demographic makeup. Buffalo, New York, Rochester, New York, Milwaukee, et cetera. So you can see the benchmark communities in the US average are kind of trending down while Grand Rapids has plateaued. Continuing that story, you can see here, this is spending per hospital admission. And you can see that while all communities, the spending per admission is growing, Grand Rapids has been growing faster than any of the comparison communities. So why is this important? Because low healthcare spending and utilization represents an advantage, especially to employers and businesses looking to set up operations. So it's concerning to watch Grand Rapids possibly lose one of its advantages over its comparison communities. So it's something we're going to continue to watch in future health checks. Another trend that we drew attention to, this is a little bit more good news. This is Medicare spending per beneficiary. And you can see, especially from the years 2015 onward, Grand Rapids spending was growing faster than any of the benchmark communities, to the point where in 2018, for the first time since the report started, Grand Rapids had the highest healthcare spending out of any of its comparison groups. Now that we've added a new data point, the growth has slowed, and that's good news, but we're going to continue to monitor this because, again, high healthcare spending on Medicare beneficiaries is concerning as they represent such a vulnerable group that does consume a lot of healthcare treatment. Next, to major medical conditions. What we've historically done in the health check report is monitor 6 chronic conditions and how spending on those conditions is different on both sides of the state. For obvious reasons, these chronic conditions, by being chronic, they don't go away, they affect quality of life, and they require a lot of treatment, a lot of expensive care. So it's important to monitor if the two sides of the states are having different experiences with these conditions. So like I said in the first slide, really remarkable stability in terms of how spending has changed over the past year. I've looked at the data from 3 health checks, and this is the most stable we've seen. And it's very surprising given how disruptive a year 2020 was, to say the least. You know, if anything that happened, we saw, so this is showing the two sides of the state. We have Coma in dark blue, so that's Kent County, Ottawa County, Muskegon, and Allegan counties. So first comparing the two sides of the state. So just focusing on the dark blue and the light blue bars. Over the past year, if anything, there was kind of small increases in spending in the Coma region and small decreases in spending in the Detroit region. So that's opened a bit of a gap between the two sides of the state. And that could exist for a whole bunch of reasons. But one of the reasons that we wanted to investigate was it could be that the two sides of the state have different underlying health characteristics. Just, you know, one region might be healthier than the other. So what we did with that maroon bar in the middle was basically do kind of a thought experiment to estimate, well, what would Coma's spending look like if they had the same underlying health characteristics of the Detroit population? And as you can see, once we make that adjustment, spending per person with these diagnoses, for each one of the diagnoses, higher in the Coma region compared to the Detroit region. So spending per person, quite high. I want you to remember coronary artery disease. You can see that's where there's the most noticeable gap between the two sides of the state in spending per person. I'm going to refer to that again in a few slides. Okay, if there was stability in those measures, here's a measure that just completely changed from last year. So what we have here is telehealth utilization. So the telehealth visits per person in the two sides of the state, Coma region and Detroit region. So a little bit of reference, last year for the 2019 data, the highest bar there was at a height of 0.12. So that was the greatest telehealth utilization across all these conditions. And as you can see, from 2019 to 2020, there's just been an explosion of telehealth use. We're talking thousands of % increase in telehealth utilization in both sides of the state, which is remarkable. It's almost difficult to compare the 2 years. We're talking about an order of magnitude and almost a 2 orders of magnitude increase in telehealth utilization, which is really remarkable. So there were multiple factors behind this, some coding changes that we've discussed with our industry partners, but as near as we can determine, the lion's share of this massive increase is due to the COVID pandemic. Not these other kind of technical factors that just there was an explosion in telehealth use as in-person care became restricted by the pandemic and providers and patients turned to telehealth as an alternative. You can see that it's super high in conditions like depression, less so in other conditions that require more in-person care. So that's really remarkable that we see such a level of telehealth utilization. Okay, I'd like to turn to disparities now. This is going to be the main topic that I discuss. So Dr. Aslam and I, we investigated health disparities by both income and race. I'm mostly going to talk about disparities by race today because generally we saw similar patterns in disparities by income on the two sides of the state. So let me show you what we did. So here, the two rows are the Coma region and the Detroit region. And in the middle column there, focusing there first, you can see the average income level and the racial distribution for the two regions. Now, the payer data that we have, this is data on privately insured patients. Now, for privacy reasons, there's not a lot of identifying characteristics in that data, right? So that we can figure out the income and the race of the different members. But what the data does contain is zip code information. We do know the patient's zip code. And why that's useful is because the Census Bureau keeps detailed demographic information by zip codes. So essentially what we're able to do is split the data out by the zip code of residence of the patients, and thereby try and make some kind of inference about what different experiences different patients are having based on the income and racial distributions of their zip code residence. So what we did, going from the middle column to the left column there, what we did, we isolated those patients that lived in a set of zip codes that zip codes that made up 20% of the regional population and had the highest weighted average in terms of the share of residents that identify in the census as white. So you can see we call these the high share white zip codes, and you can see in the two regions similar racial distribution, so high 90s in terms of percent of the population identifying as white and relatively low percent of the population identifying as black. Then we did the same thing, this time isolating zip codes that again made up 20% of the regional population and had the highest weighted average of residents identifying as black in the census. And these across regions, the high share black zip codes, you see the racial distributions are quite different. The zip codes in the Detroit high share black zip codes, majority black, whereas they are a plurality in the Coma region. That's going to become a factor we could talk about in the Q&A session. But essentially, we're going to look across these different quintiles in the data and see if the experience with these chronic conditions is different depending on the race of the racial distribution of the zip codes, and in that way try and say something about health disparities. So first, we have average risk score. So risk score is a measure that's trying to account for the underlying health characteristics of the zip code populations, their illness severity, and their risk factors. And first, focusing on Detroit for a second, the three bars on Detroit, we have the region average in the middle, and then the high share white and high share black zip codes on the two ends. And as you can see, in terms of underlying severity and risk factors, you see the highest severity and risk among the residents of high share black zip codes and lower severity and risk among high share white zip codes. But you see the opposite pattern when looking at racial disparities in the Coma region. In fact, you have the lowest severity and risk among the high share black zip codes of the Coma region and higher among high share whites. And this is going to be a pattern that we're going to notice different patterns in the health disparities in the two regions. Next, we are moving to, so this is, we took all the chronic conditions, the total number of months of insured patients, and we also considered months that we labeled healthy months. So these are where the individual is between the age of 30 and 39, doesn't have any of these chronic conditions, and has relatively low healthcare spending. In the Detroit region, not much racial disparity in terms of the share of total insured months are classified as healthy. But again, perhaps surprisingly, and what wasn't reflected in the disparities by income, is that we have the highest share of insured months that are considered healthy among the high share black zip codes in the Coma region. And that's not what we found when we looked at distributions by income. So now what we're going to look at is the kind of difference in the prevalence. So that like how many insured months have an asthma diagnosis. We're going to do this for a few of the chronic conditions. So focusing on the Coma region first, you can see there doesn't appear to be much racial disparity in terms of the prevalence of asthma among total member months. But then looking at the Detroit region, you can see that asthma is much more concentrated among the high share white zip codes, and it makes up less of a share of total months, with the high share Black zip codes. Now, that's not necessarily because asthma rates are low in the high share Black zip codes. It's just that other health chronic conditions are more prevalent and make up a larger share, and that pushes the share for asthma down. Low back pain, we don't see much racial distribution at all in the Coma region, but in the Detroit region, again, fairly low share of total months among the high share Black zip codes and high among the high share white zip codes. And the next slide is going to reveal the big reason why that is. So this is looking at diabetes, prevalence of diabetes among the different zip codes. And as you can see in the Detroit region, very high diabetes rates among the high share Black zip codes. So when it comes to which these chronic conditions are most affecting each group of zip codes, very clear that diabetes is falling disproportionately on the high share residents of the high share Black zip codes. But again, in the Coma region, we don't see that pattern. There's less of a disparity, and if anything, we actually see lower diabetes rates among total months for the high share Black zip codes than we do the high share white zip codes, which is interesting. This has implications for how we approach the healthcare problems in the two sides of the state. Lastly, share of total months with a diagnosis of depression. Again, the opposite pattern in terms of how the prevalence of depression changes among total member months as we look across racial disparities. Depression being more highly concentrated among the high share white zip codes of the Detroit region, but more highly concentrated among high share Black zip codes of the Coma region. Now, this is my last slide, and what I wanted to point out here, remember I asked you to pay attention to the coronary artery disease spending on the other chart where it looked like spending per person in the Coma region was really, really, really high. Well, this is looking at basically the prevalence of coronary artery disease among residents of the two regional populations. We don't see a lot of racial disparities here. So in each region, the bars are pretty level. But what we do see is across regions, a big difference, almost double the rate in the Detroit region compared to the Coma region. So this can be one story about why spending per person is higher in Grand Rapids, is that it could be an economies of scale story, just because there's such a higher population, almost 3 times the population in the Detroit region, and it's so much more prevalent that the fixed costs of treating coronary artery disease patients can get kind of spread over a larger population. Also, in discussing with our industry partners, what could be at work is different practice patterns. So diagnosing coronary artery disease earlier on, right, can lead to higher prevalence, but also because you're diagnosing it for less severe cases, lower spending per person. So another reason to maybe not be as concerned that the spending per person on coronary artery disease is high in the Coma region compared to the Detroit region. With that, I will turn over to our next presenter, Dr. Aslim.
Thank you, Dr. Montanera. I'll share my screen now.
That's great, Edmund.
Okay, perfect. So let me see. Can we move through the slides? Can you see the slides?
Yes.
Okay, perfect. Now, I would like to start off by describing the data that we use in this section. We obtained data from the behavioral risk factor surveillance system. It is a survey that is representative of the population in each state. And as different from the previous section, in this survey, we are actually able to identify the race of an individual, and we'll be able to track outcomes over time. And we'll group individuals as white individuals and non-white individuals, and the non-white group will include African Americans, multiracial individuals, and Hispanics. So we have 2 key findings in this section. First, we find that there is limited access to health insurance and care among non-white individuals in Coma. And second, we find that there is increased risky health behaviors among non-white individuals in Coma. And again, Coma includes Kent, Ottawa, Muskegon, and Allegan counties. So let's start off with access to health insurance by race. Light blue line is for non-white individuals in coma, and the maroon line is for non-white individuals in Detroit. We clearly see a declining trend in the percent of non-white individuals having no health insurance in Detroit. This is also true for white individuals in both coma and Detroit region. However, there seems to be limitations in accessing health insurance among non-white individuals in coma. In our report, we also have these graphs by gender. It shows that the trends for non-white individuals in coma is driven by males. Okay. Next, we look at insurance types by race. On the one hand, white individuals are more likely to be enrolled in private health insurance. On the other hand, non-white individuals are either enrolled in Medicaid or they are uninsured. It is critically important to note that females are more likely to be on Medicaid and males are more likely to be uninsured. Additionally, more than 20% of non-white individuals report having no insurance in coma, which is almost 10 percentage points higher than those in Detroit. So we think that this is an important point. So now that we have established that there are some limitations in accessing health insurance, we can now turn our attention to access to care. This figure shows us whether there are limitations in accessing care due to costs. There seems to be a non-negligible disparity between white and non-white individuals. Historically, white individuals didn't find costs to be a barrier for healthcare access. However, non-white individuals face these barriers, particularly in coma. To support our analysis on access to care, we observed the trends in having a usual source of care. I will not dwell on the spike in 2008 in coma because there might be measurement error in the survey, but I will focus on overall trends. The disparities between non-white and white individuals also show up here. Non-white individuals are less likely to have a usual source of care. And again, this is driven by males. Let's shift some gears and look at risky health behaviors. Non-white individuals are more likely to be current cigarette smokers compared to white individuals. We, however, see a declining trend in Detroit. You can see the maroon line right here, and an increasing trend in coma. You can see the light blue line right here. The trend in coma is driven by males. Now, this is an interesting graph. So we look at e-cigarette use. And if you look at e-cigarette use, non-white individuals in coma are more likely to be former e-cigarette users. So this suggests that there seems to be the case that the individuals are substituting cigarettes for e-cigarettes in coma. Well, you might be asking, why might that be the case? Well, there has been an increase in demand for e-cigarettes. That also increases the price of e-cigarettes. It could be the case that non-white individuals are more sensitive to these price changes in coma. I believe that if one decides to estimate cross-price elasticities here, they will probably find a statistically significant positive coefficient. Good. Now let's look at obesity by race. Although the prevalence of obesity was low among non-white individuals in coma before 2015, we observe an increase in obesity in recent years among non-white individuals in coma. Interestingly, there is higher prevalence among females. Okay, for the first time, this year, we obtained data on pain medication prescriptions by gender. We find that women are more likely to be prescribed pain medicines. In fact, research shows that they're given higher doses and use them for longer time periods than men. Let's indirectly look at prescription behavior of physicians. Do we observe an overprescription of pain medications among females relative to males? The answer is yes. More than 60% of females in coma have leftover pain medications. This is 10 percentage points higher than leftover pain medications for males in coma. You can see this dark blue bar. It's when individuals say, yes, we have leftover medication. This is particularly concerning because leftover medications, especially opioids, can lead to accidental poisoning or opioid misuse. Now, what do individuals do with the leftover medication? Well, most of them keep it at home instead of turning these meds at an event or pharmacy. If we want to make some policy recommendations here, I think policymakers should increase patient awareness about proper ways of disposing unused pain medications. They should also promote drug take-back programs to incentivize the use of these services. Perfect. Now, let's look at healthcare spending and employment during COVID-19. So this figure shows health spending during COVID-19 period. We obtained high frequency spending data from Harvard. These vertical dashed lines show the dates of certain policies, such as public school closures. For example, in Michigan, this was on March 16th, and we have this stay-at-home orders on March 24th, and it also shows all the stimulus payments. So the first stimulus payment in April, and then the second stimulus payment, and then the third stimulus payment, right? So last year, we showed this huge dip in healthcare spending right after the implementation of social distancing measures. You can all see that healthcare spending declined more than 60% in Michigan. This year, we extend our data and show that there's some recovery in healthcare spending, although it is noisy. In a new research of mine, I looked at how vaccination policies affect access to care and consumer healthcare spending. First, I find that age-based vaccination policies reduce the likelihood of delaying care and increase healthcare spending. We also explored some mechanisms. We find a strong evidence that there is reduced fear of contracting COVID due to these vaccination policies. And it contributes to the increase in healthcare spending. Finally, there is a huge debate about staffing levels in the healthcare sector during COVID-19. Again, in an independent research with my co-authors, Xinyi Chao and Kwalika Day, we investigate employment dynamics during COVID-19. We were particularly interested in nursing sectors, so we collected payroll-based data on staffing hours in long-term care facilities. I will report national estimates here. However, I suspect that we might see similar trends in Michigan. What we found was quite striking. The left panel shows staffing hours for registered nurses, and the right panel shows staffing hours for nurse aides. We see that there was an increase in RN staffing hours during the first few weeks of COVID. However, we see a sharp decline in staffing levels afterwards. This is mainly driven by increased patient to nurse ratios that lead to job dissatisfaction and burnouts. In fact, many of these RNs took paid travel nurse assignments. On the other hand, we see an increase in staffing hours among nursing aides. There seems to be a compositional change in nursing homes in the form of downskilling. In other words, more expensive RNs are replaced with less expensive nurse aides. I would be happy to share our paper with anyone interested in this topic. So I'll finish right here, and Jerry, we can start our Q&A.
Great, thank you guys, I appreciate it. We have several questions, very interested about some of the disparities data and some of the questions concerning some of the definitions. So this is a question perhaps for starting for Dan and then also for Erkman. So for Dan, for the disparities information you shared, does any of the data include other people of color besides the categories we looked at? And then for Erkman, for looking at the data that you shared, is there any ability to get any data or talking about the ability to get data on the LGBTQ+ population?
So to begin, we thought it was important to look at the different experiences across the two regions, especially the white and black dynamic, given the history of segregation and disparities between those two populations. So my section of the research does not include other non-white individuals. Mine is distributed only white individuals and black individuals for that reason. We'll talk about possibly coming up, but that ends up being, I think, what the literature points to as one of the big reasons for the difference in patterns between the two regions, is that while both regions have differences across zip code in terms of their racial distributions, none of the zip codes in the Coma region rise to the level of racial segregation, where you have zip codes with up to or an average of 85% of the zip code population being a racialized minority, and what that does to the individual's health. So when it comes to opportunities for jobs, transportation, phenomena like food deserts, right? Where if you have a depleted neighborhood and the neighborhoods adjacent to you are depleted, it becomes so difficult to access healthy foods, access healthcare facilities. So that interplay of segregation, right, and the differential experience of the two sides of the state, I think was an important one to study, and that's why we see the patterns we do.
Okay, perfect. I think the LGBT question is very interesting. I actually remember reading a paper that looks at how Medicaid expansion affects health outcomes and access to care among LGBT community, and I believe they were using Burfis data, which is the same data that we are using, but I need to double check whether that variable exists. But overall, the conclusion was that the Medicaid expansion actually increased access to care and improved outcomes within the LGBTQ community. But I think that's an interesting angle, and we can definitely explore that.
Great, thank you. And Erkman, I have another question for you here concerning when you're talking about nursing burnouts and voluntary quits. Yeah. Do you have any policy recommendations concerning that?
Yeah, that's a very good question. I think an important policy recommendation here relates to patient to nurse staffing ratios. So as I've highlighted before, the reason that we have observed some of these quits is due to job satisfaction and burnouts. And the main reason for that was the increased patient to nurse staffing ratios. For example, and a nurse was assigned to 20, 30 patients, right? And many states don't have regulations on these ratios. So an important policy for states to consider is to, regulate these patient to staff nurse staff patient to nurse staff ratios and maybe put a cap on it. Maybe say, a nurse should only be assigned to 5 or 6 patients and regulate this. And I think this is an important debate, and we see new papers coming on this topic and discussing these regulations.
Thank you. And I have a question for Dan. You talked earlier about the risk scoring. What sort of factors are used in that risk scoring mechanism?
Right. So this is an excellent question. So there's a history of risk scoring going back to the 1980s in the United States, really pioneered by Medicare, that has the most transparent process. So Medicare's risk scoring is typically based on age and the presence of a set of comorbidities, a set of health conditions, and based on, basically adding up the number of comorbidities, the number of conditions the person has, and that contributing to how high we rank their severity or their risk. Now, what makes it more difficult is that while Medicare is very transparent about what factors it uses for risk scoring, there are these alternative risk scoring systems that are developed by the private sector that use different factors. So the one that gets used by the insurer partners in this study was developed by Johns Hopkins University, Johns Hopkins Health Center, and the thing is, it's proprietary, right? It's private, and it gets licensed to other health systems. So it's not as transparent in terms of what factors they look at. My understanding from the literature is, where are they different? The Medicare risk scoring and the Johns Hopkins is that Johns Hopkins also incorporates past healthcare utilization. So, has the patient been hospitalized recently? Also incorporating previous prescriptions, right? So the prescribing behavior, and Medicare does not account for those because they don't want to create the incentives among insurers and providers to unnecessarily increase provision in order to increase the risk scores and increase their reimbursement. So as far as we can tell, given the limited transparency, we're talking about age, the presence of comorbidities, past healthcare utilization, and prescriptions for the patient are the big drivers of differences in risk score.
Thank you. And Erkman, I think a question for you. Do we have any past data looking at the trends of the gender difference in pain medication dosage and duration? And also related to that, could you perhaps explain why you think women are prescribed more pain medication than men in the region?
Yeah, thank you, Jerry. So there are certain modules on Burford's data, and I believe that this pain medication module doesn't exist every year. So that's why we were able to obtain that module for this year, but I have to go back and see what years that module is available. So if we have it for previous years, we'll make sure to include it in our analysis. And the question about pain medication is very important. So previous research shows that women experience pain differently than men. In fact, women are more likely to report more pain than men. And, they have some types of, they're more likely to have long-term chronic pain like migraines and back pain. And these are, more common in women. But, perhaps more importantly, women may become dependent on prescription pain medications more quickly than men. And we have seen in figures that they're more likely to report having leftover pain medication. So that's why I think it is very important to promote drug take-back programs, because it seems like most of these individuals are keeping this leftover medication at home. Thank you.
Thank you. We might have time for another question. I do want to point out that here we're showing a selection of the full report, and the full report and the presentation will be available on the website where you went to register for today's presentation. Dan, I think I have a question relating to some of your earlier data in the disparities section, I think. Oh, sorry, not the disparities when you talk about expenditures. How are healthy members defined, and why is the cost of healthy members somewhere still around $5,000 in healthcare expenditures?
Right. So healthy members is a term that we came up with in previous health check reports. So the way we defined it is that the member is between the ages of 30 and 39. So that as a result, we're going to end up dropping a lot of healthy policyholders, like children, for example. I think the idea was to create a group that looks similar in age profile to those who have a lot of these chronic conditions. But the three criteria were their age between 30 and 39, two, that they didn't have any of the 6 chronic conditions that we looked at, so no asthma, no coronary artery disease or anything like that, and that their overall healthcare spending was below $450,000. So I guess the question was, well, if they're so healthy, why do they still have the, why is healthcare spending, in the thousands of dollars? So, that definition still can include individuals that have health problems, right? Just because they don't have asthma or diabetes doesn't mean they didn't suffer a car accident or something like that. And as long as their healthcare spending for the year came in below $450,000, they turn up in our data as healthy members. So I would say that's the big reason that there is still healthcare spending among the healthy members. It's not that there's absolutely nothing wrong with them and that they never went to a doctor's office during the year or anything like that. It's just that they didn't have the 6 chronic conditions that we did look at.
Okay, well, thank you very much, everybody. I think that's it in terms of time for our question and answer session. Erkman, just a reminder to stop sharing your screen, I think, and then we'll hand it back to Dean Koch. Thank you, everybody.
I can learn to understand you much better if I can get familiar with the way you talk. I need your
Okay. Thank you so much to our presenters, Dr. Simons, Dr. Eslim, and Dr. Montanera, for such timely and excellent work on the 2022 health check. As Dr. Simons mentioned, the health check will be available on the Health Campus Events website later, early next week. And all participants who registered will receive that link for the health check. So watch for that in your email. It is now my pleasure to moderate the next section of our health economic forecast, the panel presentations, to hear the latest trends in health in the state and in West Michigan. Our first presenter to share the state perspective is Elizabeth Hertel, the director of the Michigan Department of Health and Human Services. Good morning, Dr. Hertel.
Good morning. I am not a doctor, though. Just to clarify.
My apologies, director.
Okay.
I meant to say Director Hertel.
No
My
problem.
apologies.
I don't want people to get a false sense of who I am here. Good morning, everybody. Thank you so much for inviting me here. I'm really grateful to be part of this fantastic panel and this program this morning. A lot of great information from the presenters before, really, so thank you. We'll go to our next slide here. Thank you. So this week we had some good news. We are cautiously optimistic as we believe we're coming off what were our highest case numbers of the entire pandemic. Models are predicting that we are either at or near the peak. I actually think we may be on the downside of that peak actually right now. Most data from this region and most regions across Michigan are following the line of statewide trends, and this includes that decrease in positivity and case rates. At the state level, through our local partners, we're continuing to encourage people, however, to get vaccinated, get that booster, wear your mask, and test either at a testing site or trying to use at-home tests, which are becoming a little bit more easily available right now to avoid continued spread of COVID-19. In terms of those testing supplies, and in addition to the at-home tests that are available from the federal government, we've continued to work with schools to make testing available to students and their families through the My Backpack program, through which we have distributed over 175,000 over-the-counter tests directly to Michigan families, and that increases each week. We are continuing the My Safe Schools testing program, which has provided more than 1.4 million antigen tests to schools since 2020. In addition, we've expanded testing resources for other households by distributing free at-home tests to some public libraries. And we've sponsored thousands of testing events and tests at points of entry, communities, and neighborhood sites across the state. Next slide, please. On a statewide scale and in most regions, hospital census information has indicated that hospitalizations and ER visits with COVID positive patients are declining. Although we still have some federal support teams deployed in facilities in West Michigan and elsewhere in the state, our hospital administrations have told me that there is still strain on the system, and we are again cautiously optimistic as we are starting to see some of those numbers decreasing across regions. On to vaccines. From our vantage point, vaccines continue to be our absolute best way forward, and our strategy in 2022 is based on three primary goals: preventing death and severe outcomes from COVID-19, protecting our healthcare capacity, and keeping our vital infrastructure, which includes schools, functioning while planning for recovery. While vaccination has slowed since the beginning of the rollout, we do continue to see people getting vaccinated and getting their boosters once eligible. We are hopeful about the possibility of authorization for vaccine for children under the age of 5 very, very soon. And we continue to work with our stakeholders and other community members to continue to reach those communities and neighborhoods where vaccine coverage remains low. COVID-19 and moving forward from the pandemic is a major priority for us, but we're also working on several other priorities that will make a difference throughout someone's lifetime. Today, I'll highlight just a few that overlap with findings in the latest West Michigan Health Economic Report: health equity, behavioral health, and staffing, or healthcare workforce. Improving health equity is a priority that spans so much of our work and will require us to take a look at whole systems, not only how we work together as state government and existing policies, but also how we interact with individuals, organizations, and communities across the state. The pandemic certainly magnified and drew broad attention to disparities that exist and have existed for some time, and further demonstrated the importance of addressing some of those systemic health equities. As this group certainly knows, social determinants of health play a role in whether or not an individual or family has access to affordable, reliable health care and in a person's overall health outcomes. It's important to recognize that social determinants of health impact access to care in communities of all sizes across the state, but they disproportionately contribute to significant racial and ethnic disparities. And this will be part of our work in the coming year. As we're looking at how to improve opportunity for healthy outcomes for our friends, families, and neighbors, we need to make sure that we are addressing the root causes of less desirable health outcomes over someone's lifetime. Every Michigander deserves access to safe, affordable, and accessible behavioral health care in their community, when and where they need it. After the isolation and stress of the past couple of years, I expect that we will continue to see the demand and need for these services increase. Our public behavioral health services offered through our 46 community mental health and 10 prepaid inpatient health plans serve over 300,000 people in Michigan, which includes youth and adults with care needs, intellectual and developmental disabilities, and substance use disorders. However, only 1/10 of the 1.3 million Michiganders who live with behavioral health disorders are served by our public behavioral health system. Over half with a behavioral health diagnosis and nearly 70% with a substance use disorder do not receive treatment. As you all know, this impacts not only the individual, but their families, their communities, and we have a tremendous opportunity to make changes here. It is heartbreaking to me that this is not always the case, and it is one of my top priorities as director. As all of you who've been watching and listening today know, behavioral health is just as important as physical health. It is critical that people be able to access services in their community. We have taken steps forward, such as the expansion of our CCBHCs and resources for students, but there is so much work ahead of us. And in the context of COVID-19, our Behavioral Health Administration has established a host of resources for people who are in crisis or simply feeling isolated based on what's occurred over the last couple of years. But we know that one of the most significant barriers to mental health care in Michigan is access. We have incredible partners in healthcare, but we can always improve on any system. Resources in schools remain scarce, and our kids spend much of their day in this environment. So you will always hear support from me for policies that drive more behavioral and mental health resources in schools. The governor has made investments that included resources to help schools hire mental health professionals, and so far, they've hired 560 additional nurses, counselors, and social workers. We continue to work with partners on a plan to build from what is already available and improve access to and delivery of behavioral health services to children, particularly children enrolled in the Medicaid system and through our foster care system. The governor also mentioned in her State of the State her interest in a loan repayment program for mental health professionals, which I will touch on in a moment. Together, our progress to date and these new proposals can help Michigan take a big step toward giving individuals and families the care they need. And healthcare staffing. So I mentioned that we're continue to work with the federal government on our staffing needs in the short term. Last year, we were successful in our request to extend the wage increase for direct care workers from the state budget. And last week, Governor Whitmer, as I mentioned, in her State of the State, supported expanding our Michigan State Loan Repayment Program for behavioral health providers, which will help us attract and retain talent in that area of healthcare, and again, improve access to behavioral health services. I look forward to continuing to have conversations with our providers and our other partners to talk about other solutions to expand our healthcare professional network. This has been a difficult couple of years for healthcare facilities and workers. I've said it before, but I will continue to say it for everyone participating today who works in healthcare or public health in any capacity. Thank you so much for your commitment, your dedication, and for the work that you do each and every day. Thank you so much. I'll turn it back over to Dr. Koch.
Thank you so much, Director Hutel, for your presentation. Our next three presenters are healthcare leaders and experts from health systems in West Michigan. Our first presenter is Dr. Matthew Bierzak, President and Chief Medical Officer from Mercy Health. Dr. Bierzak.
Well, thanks so much. It's so grateful to be with you all this morning. I think that was a really great review of the health check and really a lot of interesting data for us to consider. Thank you, Elizabeth, as well for your presentation and for the note of gratitude to our healthcare teams. It's been an incredible journey for them, and appreciate the recognition. As mentioned, I serve as president of Mercy Health St. Mary's. Now officially since the fall of last year, and I am so honored to do so. This is, truly an incredible organization where I was literally born and where I've worked professionally for almost 15 years. I'd like to share that Mercy Health St. Mary's is a key ministry within Trinity Health. Trinity is a national health system that spans over 22 states and remains grounded, as do we, in our mission to be a compassionate and transforming healing presence within our community. So as we look at trends in healthcare, as we look at opportunities and the forecast going forward, know that it's through that faith-based and mission-focused lens. here's some context about our organization. So as we speak about healthcare economics, as we talk about the workforce, challenges, opportunities, I come representing an organization that employs over 3,000 colleagues within the greater Grand Rapids area. And, you know, we've been keeping them busy with 260 adult beds, including our birth center, a specialized 28-bed inpatient psychiatric medical unit, and a 15-bed neonatal intensive care. We certainly stay busy, and you know, I'm really proud that throughout the course of this past year, the many challenges, as Elizabeth described it, is very difficult. We were still able to provide exceptional care to the community, and that care has been recognized by Newsweek, by U.S. News, and we were excited earlier this year to learn that that Watson and Fortune rated us as the 4th major teaching hospital in the country. But you know, there's no doubt that the year was challenging. We started it with this push to bring a much anticipated vaccine to the community, and we did. We vaccinated thousands. We weathered, you know, a couple different surges of COVID, but our healthcare team is wounded, figuratively and literally. 2021 saw increases in workplace violence. Daily at our safety huddles, we talk about the impact that has on our colleagues who've been hit, they've been kicked, assaulted, some so severely injured that they've had to take time off of work. But our colleagues have also been wounded by the impact of the pandemic. And there was a comment made during the panel that described it as a moral injury. That might be a good descriptor. Death rates have prompted us in the December to rent a refrigerated unit to augment our morgue capacity. Our colleagues were seeing death that in many cases was preventable from safe and effective vaccines. Our nursing staff held the hands of parents that now are without children, wives who are without husbands, children without their mothers, and our team was there for all of it. We've been impacted by this past year, but we're looking forward to. And so we talked about several different healthcare trends. And I wanted to just share a little perspective on a few key themes. And I think it's you know, first and foremost appropriate to start with talking about the workforce. We've certainly been impacted as everyone has with a substantial contraction of our workforce. And more recently, we've weathered quite a bit of illness in these last couple months as Omicron has really burned through the community. But as we look forward, as we look to the future and different trends, I'm really grateful that we're seeing, I think, a marked emphasis on how organizations, hospitals in particular, are looking at diversity and inclusivity in the workplace. I think at Mercy Health, we've been lauded by the business community for evidence-based objective hiring practices that really remove biases from the candidate selection process. We've also been recognized at how we develop our workforce and how we offer advancement opportunities through the organization, education, training programs, and support services to really remove barriers to professional success. That could be childcare, it could be transportation, it could be housing. Our St. Mary's Foundation supported a Wheels to Work program, and they supported rides for actually about 1,800 rides for our colleagues over a 6-month period. So it's through these kind of opportunities, through coaching, through our Rise Up program and others, that we're seeing colleagues really advance through the system, and at the end of it, increase their take-home wages by, in a composite, hundreds of thousands of dollars. So this is exciting work. We talked next about innovation and personalization, and you know, the health check spoke to patent trends as a proxy for innovation, but you know, I think this is an important marker. There's so much more in terms of what we're seeing in innovation, especially in healthcare technology and in personalized medicine. So this gentleman that you see in the picture here, this is Paul, and he was the recipient of a kind of a novel device that we use for patients who are treated with specific movement disorders in the Howenstein Neuroscience Center. And we were the first hospital in Michigan to use this new remote patient care technology called Neurosphere. What was exciting is that Paul actually had his first device adjustment outside the office while he was camping. And the teams and him and the manufacturer were just cheering him on as they were able to make these changes. And I think this promises a big opportunity for us because we're seeing more specialized devices that can really change the lives of people and allow for remote monitoring and adjustments. We're also seeing this shift towards increased personalization. We're seeing that in the neuroscience space, but when we're talking about genetics and we're talking about epigenetics, those factors that really impact how genes are expressed, we talk about how they influence disease really in a number of different areas. In our comprehensive breast center and the Lax Cancer Center, we've been using genetic testing to look at growth and division of cancer cells and other tests that look at how cancer mutates to really guide individualized therapy options. We use genetic testing to assess and predict patient risk. And these are tools that I think we're going to be using even more across many different areas and specialties. We're using artificial intelligence. We're using predictive modeling really on a daily basis. Risk adjustment tools for either readmission to the hospital or for mortality that are based on pretty complex machine learning algorithms. And this results in not just better outcomes, but because it allows us to really tailor treatments, tailor interventions towards specific risk populations, it's going to result in lower care or lower cost of care overall, while still being able to provide high quality care. There's been a lot of conversation. Elizabeth talked at length about behavioral health. And one of the things that we've been able to share recently that I wanted to bring up again today is this exciting partnership for us in the behavioral health space. Mercy Health St. Mary's and our community mental health agency, Network 180, have formalized this public-private partnership to stand up a behavioral health crisis center. And I think that this is going to be huge. It's going to help really allow us to meet a need in the broader continuum of behavioral healthcare tools that we just need as a community to address the gap that exists. The vision is that individuals will be able to walk in 24/7 and be assessed. And at the heart of this will be a crisis stabilization unit that will allow for rapid and accessible intensive treatments that will be able to, I think, stabilize a lot of behavioral health crises. And again, I think ultimately at a lower cost of care. And I think this is going to dramatically reduce, the delays that people have when they're in a crisis. So I'm really excited about where this work goes. Lastly, I wanted to focus around partnership. I think one of the silver linings of the pandemic is that it's given us this gift of talking and collaborating more as systems than I think we've ever have before. Dr. Grifka, who's going to be speaking a little bit later, will probably touch on the great partnerships that Mercy Health and U of M Health West and Michigan Medicine have forged in cancer care and in cardiovascular care. I think these are really going to be game-changing relationships for the community as we put aside health system competition and really focus on how we create seamless, comprehensive programs in both of these spaces. But we're also partnering in the community to help us more thoughtfully collaborate on some of the important issues that we heard earlier today around health disparities and how we really improve diversity, equity, and inclusivity. And so we're working with and supporting the aims of several different organizations: the Grand Rapids African American Health Institute, the YWCA, the LGBTQ Healthcare Consortium, the West Michigan Asian American Association, and the Hispanic Center of West Michigan, who are also working to address and end health disparities. Over this past year, what we found is that this work has opened up even more partnerships between these agencies and all driving toward addressing the community's greatest needs as it relates to health and the communities that are represented by them.
1 minute left.
We acknowledge that among these disparities that we discussed, the state of mental health is just a crisis across all races, genders, and ethnicities. So I'm going to use this last minute to share a sneak peek at a public service announcement that's going to be coming out soon, and thought I'd share it with you today.
I felt like I lived in this fog of fear.
I would have called myself lost.
Alone.
I felt alone.
Me sentía asustado.
I was scared. मुझे पता नहीं था किससे मैं बात करूं.
I didn't know who to talk to. I didn't know where to turn. I felt like I was at a dead end.
But then I found someone who could help.
I've sought assistance before.
But it didn't work, and I'm glad I tried again with somebody that could help me.
I realized I need to take care of my mind, body, and spirit.
Encontré mi felicidad.
I'm not alone. मैं अकेला नहीं हूँ.
I'm on a new path. I'm not saying life is perfect now, but the path is more clear.
I found my way forward.
There are resources for all of us.
If you are needing to connect, someone is here for you.
I think such a powerful message about just the power of partnership. So thanks for the time, and look forward to the panel discussion.
Thank you so much, Dr. Biersack. Our next presenter is Dr. Daryl Omuchi, President of Beaumont Health Spectrum Health. Dr. Omuchi.
Let me share my screen. Give me one moment here. And almost there. There. All right, well, thank you. Well, I'll start with the elephant in the room, at least for us. You can see, and Dean Koch described my title. It's actually President of BHSH, Spectrum Health West Michigan. As you probably heard, Spectrum Health and Beaumont Health merged together earlier this week, and we purposely chose a relatively awful name to start because it's very temporary, and we hope to have a new name in the coming year. I will start by saying thank you to everyone, and as Director Hertel commented on, as did Dr. Biersack, 2020 and 2021 have been incredibly hard for everyone, particularly those of us in healthcare. And I had the pleasure of speaking at this event last year, and these were my slides, all on one, describing the lessons we learned from COVID. And unfortunately, those lessons persevered through the year, and if anything solidified. I will echo what Director Hertel commented on, that our numbers are finally improving. We've really been in a surge here really since the beginning of the fall, and it has been incredibly challenging, but we're seeing a light, at least at the end of this tunnel, and we are hopeful. My goal today is not to talk about COVID, in spite of the fact that that seems to be all that we're talking about these days. I think talking a bit about what we're investing in and what we believe the future of healthcare looks like would hopefully be helpful and interesting to all. And so these really are four pillars, focusing on affordability, which the health check data really calls front and center, making it easier to access and use healthcare, a focus on the community, which is absolutely vital, and then really having a goal of promoting health as opposed to solely treating illness. And so here is a slide where you've all seen this data before, US healthcare expenditures as a percentage of our GDP and projections going out to 2027. For those that weren't aware, at current run rate, the Medicare trust fund is slated to be insolvent at some point in 2024. That date keeps getting shifted closer. So we are absolutely headed for a crisis that we're not going to be able to pay for the care that we currently are delivering. And really, if you think about why it is so expensive in the US and why care has evolved the way it is to really focus on treating illness as opposed to promoting wellness, it's because payment models in the US for years and years have really focused on the left of this panel far more than the right. The left is hospital-based care, then you move to office-based care, then home-based care, and finally, promoting health. Ultimately, future payment models, which we are involved with, and I know many others are, really have to focus on promoting health, treating people at the lowest cost settings, which often is their home, and ultimately, we all need hospitals. COVID-19 has shown us that. We need hospitals, we need ICUs, we need quaternary care, but that shouldn't be front and center. That should be to support the health of the community. And so next, I'm going to move on to ease. And I always laugh about healthcare. We have a slide that's somewhat akin to the left picture here, where we show just the amount of regulation that surrounds healthcare delivery in the US. It is mind-numbingly complex, and healthcare is probably the most complicated industry in the US. And then you think about something on the right, Starbucks. Starbucks has an app that we all use, I'm sure. Sometimes too many of us use it, and we spend way too much on it. but nonetheless, it is an app that is easy. It is uniform. You can order your coffee, show up and have your coffee ready for you. We have to move somehow from this complicated system that we have to something that's much more akin to Starbucks. Not to say we'll ever be cookie cutter, but we have to get better. And so how are we going to do that? It really is data. The challenge with data now is we have too much of it. There is so much data within electronic health records, and with apps and Fitbits and Apple Watches, it becomes almost impossible to manage. And so that data, first of all, has to be interoperable. It has to connect. There was new federal legislation that was enacted over the last year that makes that much easier, and going forward should be much easier for all of these different disparate systems to connect. But in reality, even with all that connected data, it is too much. As a heart rhythm doctor, I cannot tell you how many patients would start sending me Apple Watch data, Fitbit data. It is just too much for all of us who are in healthcare to manage. And so the next step on this is going to be significant advancements in machine learning and AI to actually give the healthcare providers the critical data and to give back to patients the data that they need. And so I'm going to give you an example of current state and potential future state that we're investing in. In current state, you have someone that has an identified concern. They call to schedule a visit, they travel to the appointment, they get to the appointment, say a procedure is scheduled as a result, they wait to get the report, they have follow-up, and then hopefully they're doing well. Each one of those steps requires input from the actual patient themselves and likely dozens of healthcare employees, providers, nurses, billing folks, scheduling folks, and so forth. In a future world, instead of having people, which are subject to burnout and doing things that aren't really the most fun to do and are incredibly expensive, we have to get to a world with predictive modeling that can actually help a person identify a concern maybe before it's serious. Personalized digital assistants that will help them schedule an appointment and be ready to see a provider, an AI healthcare advisor that actually can navigate them through the procedure and bring the results to them. And then finally, some conversational AI follow-up that will make sure that they're doing well and port them to the right resources if they need it. This is all part of the future. We're just not quite there yet. And then shifting gears a little bit, I think if anything, COVID has shown us the importance of the community and partnerships, just as Matt had described. And really, health systems need to partner with public sector, private sector, and help the community heal and get better. And some of this, and these are just a few examples of what we've done at Spectrum Health, our maternal infant health program, which has been going for many, many years now, has reduced preterm birth by 29% in those enrolled. Our Strong Beginnings program serves underserved women who are pregnant with adequate prenatal care, postpartum exams, well child visits, and breastfeeding duration. And we have significantly reduced the number of preterm births in this high-risk population. Our school health program, much like Director Hertel talked about the need for more investment in school health, started in the late 90s with one school district. We're now up to 29 school districts, and we serve over 90,000 children in 10 different counties. These are areas where we have to continue to invest to try to improve the health of our community. And then finally, why are we doing all of this? It's really to promote health and focus on health. And so when we think about the health check report early on, about the cost of care, about the cost of these chronic diseases, one of the things that we're most proud of is that we invested very heavily with both dollars and resources and expertise to develop our first advanced primary care clinic. This was opened in September of 2020, so about 15 months ago, and this clinic completely transformed the model of care. This is a clinic that focuses on polychronic, so patients with multiple significant chronic diseases who are elderly, and we wrap services around them in a way that's very different from traditional primary care. Instead of a primary care provider having upwards of 2,000 patients in their panel, in this clinic, they have closer to 500. They spend significantly more time with their patients, and the entire team wraps services around to ensure the patients get what they need when they need. And you can see we now have 1,000 patients in our first clinic. We have closed their gaps in care almost 100%, which is really amazing. And we've reduced their ED visits per 1,000 by 22% in a very short time frame. These are patients that have a very high likelihood to go to the emergency department because of their illness. And by preventing them from going to the ER, we're actually keeping them healthier at home. We're opening 2 more of these clinics in the coming months, and we hope to expand more and more on this to reduce the cost of care. Additionally, not all people in our community have that many illnesses and need that level of care, but everybody needs primary care. Everybody needs prevention. And we are almost done redesigning our entire primary care network, which includes approximately 500 providers, to focus on value, to prevent people from coming to the emergency room, to close their gaps in care. And you can see here just one example that we initiated during COVID, a second level triage function where patients that are part of these primary care practices who were thinking of going to the ER for an acute need were able to have care delivered either remotely, virtually, or via the telephone, or ported to one of our offices with expanded hours. And we prevented almost 7,000 of them from going to the ER, which saved an estimated $5 million and clearly kept these patients healthy. And so with that said, I will tell you that, oh, thank you. With our new system, with BHSH, again, soon to be something with a much flashier name, with our new system, our strategic plan will still emphasize all that I described here. We're really here to try to make healthcare more affordable, easier to access, exceptional, and focus on an individual. We're really excited to partner with all of you and with our other great partners as part of this panel. And I look forward to the coming year, hopefully with a lot less COVID. And with that, I'll turn it over to Dean Koch.
Thank you very much, Dr. Almucci, for your presentation. Our final presenter is Dr. Ronald Grifka, Chief Medical Officer at University of Michigan Healthcare West. Dr. Grifka.
Good morning. Let's see if we can share this. All right, come on. Okay, you see everything? Well, thank you. Thank you, Dr. Koch, Dr. Plouffe, for inviting me to speak at this great conference. And thanks for all the people attending, because certainly a lot of good information is being distributed today. I have to admit, following Director Hertel and Drs. Bierzak and Almucci is a tough act, so I hope I don't disappoint. I was asked to talk about 3 things. Let's start about where we've been. And I'd like to start initially with a place that I was recently. I like to say that November 27th was a great day for the whole state of Michigan. It was a big day, and happy to have been part of that one. Where else have we been? I'm going to start with this picture in the bottom right. It's actually a hieroglyphic from Egypt where there's a little boy walking with a cane. Now, why is he walking with a cane? Well, for the same reason President Roosevelt was. They both developed polio. Poliomyelitis is a terrible virus, causes terrible disease, and thousands of kids were infected and many were paralyzed. And when you get paralyzed from polio, what happens is you wind up in something called an iron lung because you can't breathe. And hospitals had just wards and wards of these kids and adults in these iron lungs. And that's how they lived the rest of their life, lying on their back with just their head sticking out of this metal tube. And they had a mirror to look at themselves. And I guess if they were good, they got a balloon. I guess, and today you probably put an iPad there. But that's what happened with this devastating disease from polio. Fortunately, in 1955, Jonas Salk came up with a vaccine. And really great news that Dr. Salk actually did much of his training and was on staff at the University of Michigan, one of our public universities. So he was a big part of this. And this vaccine was so important that in the last 45 years, there have been essentially no case of polio that have originated in this country because of our effective vaccination program. Now let's fast forward to just a couple weeks ago, on January 21st, we had the 2nd anniversary of the first case of COVID documented in the US. In those 2 years, the world's had over 370 million cases of COVID. Michigan has had over 32,000 people die from COVID in all the healthcare systems. Fortunately, as with polio, we have a great vaccination system. And around the world, over 10 billion doses of vaccine have been delivered. And in Michigan, due to the work from the MDHHS and others, we've got over 58% of our population fully vaccinated. So if you meet someone who isn't vaccinated and they say, we're waiting for more data, you can please happily tell them we've got over 10 billion pieces of information. to prove that this is a safe and effective vaccine. And not only that, but we've had some recent data and several studies have shown that the worldwide chip shortage is not due to being used in vaccines. So we've got really good data that this is safe and effective vaccines, and we need to get this information out. What has COVID done to Michigan? Well, as you see on the graph on the left, these are the 4 surges we've had. The 4th surge is interesting. The little bump we had in October was due to Delta, pretty devastating variant. And the surge in January was due to Omicron. As you look at the graph on the right, that shows the number of hospitalizations that are caused in our state, and just in Grand Rapids. And you can see this 4th surge has lasted very long and very high number of admissions. So again, really crippling the healthcare system. So where are we now? What did we learn from this? Well, COVID did accelerate some healthcare processes. We learned how to work remotely. We never did that before. You learn the importance of having redundancies in our supply chain. You know, we can't rely on one vendor in one country to supply, let's say, all of our oxygen tubing or all of our masks. If they get locked down, then we have nothing. We also learned about our personal protective equipment. You know, we used to have 5 or 6 days in supply. Now we got 5 or 6 months. And even usage, we'd use 1 mask a day, or we'd use 1 mask for every patient. This graph shows telehealth and virtual visits. Before the pandemic, about 2% of visits were virtual. It surged up to almost 80% as people were encouraged not to come to the hospitals and healthcare systems. It's leveled out about 35 to 40%, which is a really good level. The other thing that we learned through this pandemic was collaboration between healthcare systems is crucial. You know, Dr. Bierzak, Dr. Amlucha, we spoke almost daily talking about data. How is your emergency room? Do you have beds in the ICU? Do you have ventilators? We worked together. We shared medications and vaccines, transporting them back and forth between the hospitals if we needed help with certain medications. We also found it's important to have a community message that all 3 healthcare systems provide one voice. It was important that the TV commercials, ads that we had to prove that hand hygiene, masking, appropriate social distancing, and vaccinations are going to be the way to stop variants from occurring and get us out of this pandemic. And if all the 3 healthcare systems working together to provide that one voice was really important. So where are we now? Well, where are we going? Well, I'd like to talk about 3 things. And these are really progressive innovations that add value to our community by improving patient care. Let's start with DAX, the Dragon Ambient Experience. It's essentially a program on your phone, my iPhone, that listens to the conversation I have with my patients. So I still see kids in clinic. When I go in the exam room, I don't need any notes. I don't need a chart. I don't need a computer. I don't need an iPad. I can sit down at eye level, talk to the patient, talk to the family, hear their problems, ask questions. I can examine them, then sit down again and talk to them and generate a treatment plan. Because what DAX does, it listens to the conversation, then it creates a note and it puts it into the electronic medical record. So I can focus on the patient and the family, not on documenting or clicking my computer mouse. It really preserves the intimacy of the patient-physician relationship. It shortens documentation time. It improves the efficiency of producing these notes, and then it can distribute them to a referring physician, to a specialty physician, or even to the patient themselves. It's proven to decrease physician fatigue and burnout, which is a huge problem, especially with the pandemic. And again, we're using this technology to improve the patient experience. A novel concept, using technology to improve the patient experience. We've rolled this out to our primary care offices. We'll be getting it to our specialty offices very soon. But again, using this technology to improve the patient experience. We'll talk about HRS. Lots of patients are in the hospital. They're not quite ready to go home. So they wind up staying in the hospital for days, even a week or so. Well, now we actually will send patients home, and we'll send them home with a scale, a pulse oximeter, a thermometer, and an iPad type tablet. They go home, they use this equipment, check their vital signs multiple times a day, as many times as we need. That data is automatically downloaded to the iPad tablet. Then it transfers that data wirelessly to our command center, where it's reviewed by a nurse 24/7. And every day, that nurse calls the patient to make sure the data is being collected appropriately, and they're getting better. Every 2 to 3 days, that patient gets a call from a nurse practitioner or physician. Again, make sure they're heading in the right direction. And we rolled this out about 11 months ago. And in that time, we've enrolled over 500 patients. And on average, we saved about 9 in-hospital patient days per patient. So we've avoided over 5,000 inpatient hospital days. So these patients are sitting at home in their pajamas, on their couch, eating their food, sleeping in their bed, talking to their family, not having to worry about people coming to visit them in the hospital and then can't come because of visitor restrictions. So in the process of saving all these patient days, we've saved the healthcare system over $5 million. And I'm happy to say, every patient, when they got done with their therapy, returned all the equipment. We didn't lose a single piece. So again, using technology to improve the patient experience. Honestly, talk about medical system collaboration. And certainly there's a lot of competition between systems and patients, no question about that. But sometimes it's best to collaborate. There's something that I learned last year from this GVSU health check was that Grand Rapids has the highest CV surgery costs in the state of Michigan. So we started working with Mercy Health St. Mary's and U of M Health West we're now forming a joint cardiovascular surgery program. We're going to partner with the University of Michigan Franklin Cardiovascular Center, which is top rated, a lot of research, innovation, teaching. You know, U of M has helped develop ECGs, heart lung bypass machine, this ECMO support, even cholesterol treatments. They've got multiple clinical trials and a lot of experience with heart transplants. So all systems are going to work together to develop a very efficient cardiovascular surgery program that will provide patient choice with advanced therapies and research for patients in West Michigan never having to leave West Michigan. And isn't that what our family, our friends, our community deserves? And lastly, similarly with cancer. Now, there are several cancer groups in West Michigan, but U of M Health West and the LAX Cancer Center are going to work together to have a joint cancer program. And again, we'll partner with the Rogel Cancer Center in the University of Michigan, top rated, part of the NCI. They've got over 350 cancer trials in progress, then over 5,000 bone marrow transplants. To help bring that expertise and experience to work with U of M Health West and St. Mary's LAX Cancer Center is really going to advance the care for cancer treatment for all the patients in West Michigan. And again, providing patient choice, advanced therapies and research for our community. So as we talk about using all this technology to advance patient care, I think it kind of reminds me something that Winston Churchill said as the World War II is heading in a good direction. He said, "This is not the end, nor is it the beginning of the end, but perhaps this is the end of the beginning." So I think we're really seeing this technology take us off, and we're going to see the next few years is going to be really fantastic. Better patient care, and again, as Dr. Mucci said, really focusing on wellness, not necessarily treating illness. Thank you for your time, thank you for your attention, and thank you for inviting me to speak at this conference.
Thank you very much, Dr. Grifka, for your presentation. So it's now time for question and answer. The Q&A has been a bit quiet, but there are a few great questions in here. The first one is for Director Hertel. What's the Michigan Department of Health and Human Services doing? What kind of initiatives are you addressing against violence with healthcare workers?
So we recognize that violence against healthcare workers had been increasing and seems to have increased more aggressively through the pandemic. At this point, we continue to work with law enforcement to make sure that people understand what's occurring in these facilities, not just the private hospitals, but some of the other behavioral health or other facilities as well. I think this is a really important issue that we need to keep in mind as we design a system coming out of the emergency response portion of the pandemic, and think about trauma-informed care in all settings. Although I know that won't prevent violence from everyone, I think a lot of it does have to do with behavioral health concerns from our patients. So we'll continue to work with our stakeholders and our partners to come up with strategies to address this.
Mm-hmm. Thank you. Doctors Grifka, Mucci, and Biersack, would you like to respond in terms of initiatives that you may have within your health system also addressing workplace violence?
Sure, I'm happy to at least chime in a little bit. First of all, it is truly an epidemic. If for those of you that watch the nightly news and see the violence against airline attendants and so forth, that is the tip of the iceberg. Every single day on our executive call for safety, We hear stories, and I'm sure Matt and Ron do as well, about our team members being punched, kicked, spit on, bitten, yelled at. It is unbelievable. And these are people that are here just trying to care for our community. We have done a number of things, and what we're now starting on is an education program for de-escalation for all of our team members, focusing on the areas of most need, like the emergency room first. But at the end of the day, the best thing we can do is try to prevent this from happening. Easier said than done. We also have ramped up our security presence in multiple locations, which is unfortunate, but the world we live in now. And we are looking to partner with others for new ideas, because I don't think there is a fix for this. And I do think that aside from the stress that all of society is undergoing, more and more behavioral health, and I applaud Matt for their work, and I think that all of us are doing more and more to expand behavioral health access, because without that, I think we're going to see more and more violence.
Daryl, your point's well taken. I think for the first year of the pandemic, the healthcare providers were heroes, and now they're almost villains. And it's really, the healthcare violence really has accelerated. I think we've been working on trying to be proactive and de-escalate instances before they get to the boiling point. But really, our healthcare workers are getting hammered every day. And again, they've gone from heroes to villains, and we really need to protect them, because we don't need to lose any more people from our healthcare system.
Yeah, I'm so glad that we're talking about this issue. And to both my colleagues' point, de-escalation is such an important part of this work. We've also taken steps to institute, psychiatric trained nurses in the hospital that respond, to aggressive situations and help to de-escalate along with security partners. We've worked with the county to try and bring Grand Rapids Police Department officers stationed within our emergency department. And an exciting development that we're working on is we've got puppies in training for development of a canine program, because we've seen results of the canine presence really being in and of itself a tactic for de-escalation. And just this past week, our chief nurse testified to the legislature in Lansing around new bills that will hopefully address some of the violence, at least within the emergency department. So we're trying to go at this from multiple different ways, and I'm really glad that it's a community-wide discussion.
Great, thank you for those insightful answers. Another question, for those of you that discuss telehealth as a mechanism of healthcare delivery, Dr. Biersack, Dr. Almucci, any insight on the effectiveness of these appointments as you, of course, integrate that artificial intelligence? Even Dr. Grifka, you mentioned the phone apps. So any insights or data on the effectiveness of those appointments?
I'll comment again very quickly. Actually, I think incredibly effective based on looking at our own data. And first of all, I think the trend, particularly in behavioral health, for telehealth to be the dominant form of interaction is probably here to stay. It affords privacy, ease of use, decreased cost is phenomenal. For other type of conditions, I think it's a supplement in many and not necessarily a replacement. We have partnered with a company called TytoCare, where we now distribute small little modules where a person at home can put it in their ear, hold it against their chest, and actually the provider in the visit can look inside the ear, listen to the heart, listen to the lungs. Really amazing. And I think that has absolutely replaced a huge number of visits that otherwise would have had to been in person. That will increase over time. The two challenges to all of this that we found, and I'm sure everyone else would echo, are number one, universal access to broadband coverage isn't there, particularly in some of our rural communities. There's just not the ability. And if you don't have that, it is very hard to have these visits. And number two, there are many people that have challenges with technology, even using a smartphone. All of us take for granted our smartphone. There are many people that don't have those. And if you don't have access to those things, or they're not easy, we still need to have in-person care. And there's something, all of us are physicians, and we'll all say there's something about laying hands on a person that is necessary. So I think that will be increasing amount of telehealth. It'll be helpful, additive, but not necessarily replacing all care at some point.
Mm-hmm. And I think it was mentioned earlier about what kinds of policy things or advocacy things can we do. And I think accessibility to broadband in those rural communities certainly could be, a strong initiative that we could work together on to ensure that telehealth visits then as a mechanism to increase access to care. Dr. Grifka?
Sure, I think telehealth certainly is here to stay, as Dr. Lucci said, and it's very helpful. You don't have to leave work to go to drive to the physician's office, park, then get back to work. So the ease of access is helpful. But as Daryl said, there are some people with arthritis, and they can't manage their phone, but they might not have broadband access. The other thing that's important to remember, it's not going to replace all visits. There's something that you may come in for an earache, but the physician's going to notice the mole on your back, that's melanoma, that they're not going to notice with just the telehealth looking at your throat or your ear. So we're still going to have in-person visits, and we're going to have to be really sharper at those visits because we're not going to have as many opportunities to examine patients. But certainly the ease of access and the quick ability to get patients examined and tests ordered and performed, very, very helpful. And telehealth is really going to help expedite that.
Dr. Bierzak, any comments?
I just want to underscore the comment that you made about access. The community health needs assessment identified access to care is one of the big priorities for us as a community. And I think any means and medium by which we can improve access, is helpful. And I think telehealth and telehealth solutions are going to be one of those avenues that kind of complement a whole system of tools that will help improve access. I'm with my colleagues. I still believe, and our patients told us during the pandemic that they still wanted a provider to lay hands on them in a lot of different circumstances. And so I think it will be a tool to help us, particularly in the space of access.
Well, our time is up for question and answer. Certainly, if we had been live this year, as was expressed in prior years, people lingered and talked amongst each other till 10 or 10:30. But for sake of everyone's time, we need to wrap up here at 9:45. So I want to again, once again, thank Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health for their sponsorship of this excellent event today. These are complex times in healthcare, and we've learned, and we are grateful for all of the expertise of the presenters today and our team of panelists. Thank you so much to everyone for attending today. Remember that the 2022 Health Check document will be posted on the website. It'll be available next week. And my marketing team will be sending an email to all participants with that link so that you can have access to the document, not only the slide decks of the presenters earlier on, but also the complete Health Check document. And also the recording will be available today for everyone's reference who registered as a participant. So thanks again for everyone, our presenters, everyone who attended today, those that gave questions in the Q&A, and hopefully, heaven forbid, with the COVID pandemic, we'll see everyone in 2023 live for our next economic healthcare forecast. So have a good day, everyone, and thank you for attending.